Hello everyone, my name is Leen, and in this video we're going to complete the second lecture and go over tissue repair and regeneration. So our objectives are to discuss regeneration, scar formation, and fibrosis, and to give examples of each. We're going to also go over the types of cells in regeneration. We're going to go over the main phases of scar formation, the mechanism of repair, so healing and granulation tissue formation. We're going to go over cutaneous wound healing, which is a clinical example, and discuss primary and second intention, healing by primary and second intention. We're going to also discuss factors related to delayed wound healing, and finally go over complications of wound healing. Now to quickly go over the keywords, labile means easily altered, stable means not likely to change, permanent, long-lasting, regeneration means renewal, and healing means to make free from injury. Thickening is, fibrosis is thickening or scarring of tissue. We're going to go over the precise definition later on. Granulation, the term granulation itself means the process of forming grains, but we're going to go over granulation, the definition of granulation tissue later on as well. A scar is a mark remaining after an injury. Deposition means laying down. Proliferation means to grow by rapid production. Remodeling is to alter the structure of something. And contracture is permanent shortening that produces a deformity. Now we're going to go all over these terms throughout the lecture in details and in a way that's related to the lecture. So what's the goal of the repair process, if we ask ourselves this question? Now, inflammation only eliminated the causative pathogen, and it set forward the repair process. The aim of the repair process is to restore the tissue architecture to its original state after the inflammation. So inflammation, although it did eliminate the causative agent of injury, it did result in some injury to our tissues themselves. So the repair process aims to counteract what happened. Now there can either be complete resolution, for example, after a bone fracture or surface epithelium injury, so your skin, after a cutaneous wound. Not always after all cutaneous wounds, but in a simple cutaneous wound. And there can be a scar formation, which happens in tissues incapable of regeneration, where connective tissue deposits instead of the proliferation of the original tissues, original cells of the tissue. So complete resolution or regeneration or scar formation. Now, what's the mechanism of repair? Healing or repair, you can use these terms interchangeably, is usually a tissue response to one of three, either a cutaneous wound or any kind of wound for that matter, but usually it's a cutaneous wound on the skin. It can either be to an inflammatory process in internal organs. So if there's an inflammation in your internal organs, sometimes if there's cirrhosis in your liver, for example. And 3, it can be to cell necrosis in organs incapable of regeneration. And we're going to go over which cells are incapable of regeneration, but to slightly mention them, for example, cardiac myocytes and neurons. So if we want to compare regeneration and scar formation, if we have a normal tissue, if there is mild superficial injury, and if the original cells are still slightly intact, there can be regeneration. However, if the injury is so severe that there is destruction, very severe destruction of the architecture, a scar is formed because these cells are incapable of replicating, whether it be because of they themselves are a type of cell that can't divide, or because it's so severe that they lose this function. So it can either be one of two. So regeneration occurs by proliferation of cells that survive the injury. So these cells that survive proliferate and retain this capacity because the injury wasn't so severe. However, in scar formation, Repair occurs by laying down connective tissue or fibrous tissue, connective fibrous tissue. As you can see here, there's a scar, there's connective tissue placed instead of proliferation of the original tissues. I think it's clear. Now, the term fibrosis is most often used to describe extensive deposition of collagen that occurs in lungs, liver, kidney, and other organs as a consequence of chronic inflammation. So fibrosis is that the term fibrosis is almost always related to chronic inflammation. And the presentation of fibrosis is usually clinical, so it's not necessarily a term that's used to describe what happens, but it's more of a clinical term. I think we're going to get to it with time, so as we move on with the lecture, so I'm not going to go into detail now. So for example, if I want to go over this picture, I placed like 3 pictures just for you to understand. They're all different, and I remember it being confusing to me because each one of these pictures is divided in a separate way, but if you understand the basic concept, you're gonna be good to go. So there's injury, so there's cellular and vascular response, inflammation. After the stimulus is removed, for example, if it's an acute injury, if these cells are capable of proliferation, there is regeneration. So this is one type. For example, liver regeneration after a partial hepatectomy, for example. However, if the cells are incapable, there is healing or repair by scar formation. So generally, all of these are considered healing/repair, but they just gave a specific name to each. So regeneration, if you can still form, if the cells are capable of dividing. Scar formation, so this is not really healing, it's more of a scar formation if they are not. And fibrosis, usually it's written here as persistent tissue damage. So persistent tissue damage, is chronic inflammation. So it's related to fibrosis, which is very similar to scar formation. This is another image. It's the last one, I promise. So there's normal homeostasis, there's injury, inflammation. All of this is considered repair or healing. So if the cells are stable, we're going to go over the type of cells, but if they are capable of regenerating themselves, they're going to go back to normal. For example, in the liver, because the cells are labile, they can grow. They can regenerate themselves. However, if there's, for example, a very severe wound where there's destruction of the architecture of the tissue or the organ, for example, a scar will form in which collagen is deposited. And this fibrosis is very similar to scar formation. However, it's usually associated with chronic inflammation. There's fibrosis, there's extensive deposition of collagen. I hope the general picture is clear for these. I did explain it 3 times, but I hope it's clear now. So what are these different cells? There are 3 main types, and repair by tissue regeneration depends on it. The first type are labile cells. These continue to proliferate throughout life. An example of these are squamous cells, columnar transitional epithelium, hematopoietic and lymphoid tissue cells. Now there are stable cells. I said before that the hepatocytes were labile, they're stable. So labile cells are continuously proliferating, so your skin is continuously changing, for example. Stable cells retain the capacity to proliferate, but they don't replicate normally. So parenchymal cells of glandular organs, mesenchymal cells such as hepatocytes, and renal tubular cells. So these do not usually replicate, however, if needed, they do. So if in a hepatectomy, for example, you remove a portion of your liver. Now the hepatocytes don't usually proliferate, but in this case, they will grow back. Now the final type are permanent cells. These cannot replicate whatsoever themselves. An example of these include neurons and cardiac muscle cells. Just as a slight note, I thought it was interesting. Neurons and cardiac muscle cells might have slight regeneration ability. However, it's very slight to the extent that it does not cause any difference. So it does not matter. It's very insufficient. And it's almost always injury to neurons or cardiac muscle cells almost always results in scarring. Okay, so if we want to go, so regeneration is pretty clear. The cells themselves regrow. However, if we want to go over scar formation, there are three main phases. So inflammation is the first one. We discussed it in the previous 4 lectures. 2 is proliferation, which is characterized by granulation tissue formation. And 3 is remodeling. This picture shows the timeline of what happens. As you can see, some of them overlap, and that's pretty normal. So there's inflammation, there's granulation tissue formation, then there's wound contraction, which happens during the remodeling phase. And we're going to go over each one. So 1 is inflammation. This step is comprised of the typical acute and chronic inflammatory response that we discussed earlier. But just to go over, there's the role of macrophages in repair. We discussed it in the chronic inflammation lecture. However, there's a slight change when it comes to repair. So in the inflammatory process, we discussed before that M1 macrophages clear microbes and necrotic tissues in a positive feedback loop. So these are the ones that were activated by the classical pathway, if you remember. However, in repair, M2 macrophages produce growth factors that stimulate the proliferation of many cell types and then in the next stage of repair. So these are the ones that were activated alternatively. These were the anti-inflammatory ones, if you remember. So during this phase, we're going to have M1 macrophages. During this phase, we're going to have M2 macrophages. And you can see that it slightly overlaps. So what M2 macrophages help in is the remodeling of the scar, stimulation of extracellular matrix, secretion of transformer growth factor beta. This is very important for collagen deposition by fibroblasts. And it recruits other cells such as fibroblasts and angioblasts. 2 is proliferation, which is granulation tissue formation. This image is just to demonstrate, so it's from Robbins. So there are steps in scar formation of healing, large wounds, example of healing by second intention. We're going to go over healing by first and second intention later on in this lecture. However, this is only to demonstrate. We're going to go back to this image if needed. So the main process of proliferation, the main characteristic is granulation tissue formation. So repair usually begins early in inflammation, and as I said, it usually overlaps. So it occurs as early as 24 hours after the beginning of inflammation. Now, at the site of inflammation, there are fibroblasts and vascular endothelial cells that begin to proliferate and form by day 3 to 5. So they don't happen immediately. So we begin with inflammation immediately. Then after 24 hours, repair begins. After 3 to 5 days, endothelial cells, fibroblasts, and all these types of cells begin to proliferate and form a granulation tissue. Now, this granulation tissue is the hallmark of healing. This is very important and very high yield for you to know. So the hallmark of healing is the granulation tissue formation. It consists of 3 main things. This is also very high yield for you to know. 1, vascular connective tissue. So there's new vasculature formed by angiogenesis. 2, there are fibroblasts, which help in deposition of collagen. And 3, there are inflammatory cells, mainly macrophages, like we discussed earlier. Which type of macrophages? M2. So this image might be clearer than the one before. This is just for you to imagine. You can see the collagen scar, granulation tissue. So here is when inflammation began, and slightly the repair process overlapped, and then granulation tissue happened 3 to 5 days after, and then there was the collagen scar. But if you go to this picture, here we have a normal tissue injury, inflammation that happens almost immediately, and then as early as 24 hours. Then we begin with the repair process, which happens 3 to 5 days after the injurious stimuli, and then we end with scar formation. I hope this is clear. So this image is very clear, I think. So again, normal tissue injury, 24 hours, inflammation, 3 to 5 days, granulation tissue, and then scar formation. The interval between granulation tissue formation and scar formation varies. However, if it's mentioned, I'm going to go over it later on. So angiogenesis. So it's the sprouting of new capillaries from endothelial progenitor cells. These come from the bone marrow and then travel through your vasculature to help produce new vessels. It's very simple. New vessels are formed. Why are they important? They are important in granulation tissue formation, as you can see here. If you go back again, you can see here new blood vessels. Why is this important? Because new vasculature helps in recruitment of the necessary cells in inflammation, and it facilitates the healing process. And in some cases, when there's an injury, the original cells are damaged, so it becomes even more important for new vessels to form. Okay, so before we move on, let's denote the difference between granulomas and granulation tissues, because the name is quite similar. Just as I mentioned before, the difference between Langerhans and Langerhans cells in the previous lecture, which have a slightly similar spelling, these two might be slightly confusing to some. So Exhibit A, a granuloma, is a pattern of chronic inflammation where epithelioid cells accumulate, can form a giant cell called this giant multinucleated giant cell, and the whole structure is called a granuloma. In Exhibit B, there's a granulation tissue, which is the hallmark of healing. Please differentiate between the two spellings. Okay, so during granulation tissue formation, we said that M2 cells release transforming growth factor beta. So fibroblasts are very important. They migrate to the site of injury and proliferate there, and are triggered mainly by transforming growth factor beta, released from M2 cells mainly. So this is very important for you to know, transforming growth factor beta. So if we go over the important cytokines mentioned so far in these two lectures, one is interferon gamma, released by T cells, which stimulates macrophages and chronic inflammation. This is one. Two is transforming growth factor beta, which is a growth factor released by M2 cells that stimulates fibroblasts. So what happens when fibroblasts are activated or recruited to the site? They increase synthesis of collagen and fibronectin and decrease degradation of extracellular matrix by metalloproteinases. This happens during the final process of repair, which is remodeling, so it helps in regulating it. Now there's a slight portion of the lecture that I did not include in the slides, but I would like to mention, which is the extracellular matrix. It consists of the interstitial matrix between cells. It's made up of collagen and glycoproteins, basement and base membrane. Now, the extracellular matrix is very important because it has different functions. One, it provides mechanical support to the tissue, which is the main role of collagen and elastin. Two, it acts as a substrate for cell growth and the formation of tissue microenvironments, for example, fibroblasts. And three, it regulates cell proliferation and differentiation, where proteoglycans bind to growth factors and display them at high concentration. So I just want you to know that extracellular matrix are required for tissue regeneration, and if it's damaged, repair can only be accomplished by scar formation. So even if the injury is so this is what happens when we compare healing by regeneration and by scar formation. In regeneration, the extracellular matrix is slightly still intact, so it can help. However, in scar formation, it's not. So the only way for you to close the gap is by depositing many collagen. The third step in scar formation is remodeling. So as the scar matures, there's progressive vascular regression. So the vasculature tones down. It's not as strong as it was during the granulation tissue phase. And it eventually transforms into the highly vascularized granulation tissue into a pale, largely avascular scar. So even if sometimes you look at scars you have, they look white because the vasculature regressed. Now, after the scar is formed, it's remodeled to increase its strength and contract it. So sometimes there might be the collagen deposition in wrong places or excessive deposition. Metalloproteinases are cells that help in remodeling. They remove the excess collagen sometimes, and this helps in strengthening the scar. and there's also deposition in the necessary places. So there's also a shift in the type of collagen deposited. So there's from type 3 to a stronger type 1 collagen. So there's not only removal of some of the collagen by metalloproteinases, but there's also a shift in the type of collagen deposited. Now, in a well-sutured skin wound, strength might recover up to 70 to 80% of the normal skin within 3 months. So the remodeling phase varies depending on the type of wound, depending on your body. However, 70 to 80% of the strength might be recovered. And at the end, a scar or fibrosis, if it was chronic inflammation in tissues, is composed largely of inactive spindle-shaped fibroblasts, dense collagen, fragments of elastic tissue, and other extracellular matrix components. And it's very highly avascular. I hope this is clear. Okay, so cutaneous wound healing. There is healing by primary and secondary intention. In primary intention, there is mainly disruption of the epithelial basement membrane. So here's the basement membrane, there's disruption of the tissue, basement membrane, there's disruption, and few connective tissues here that are disrupted as well. And the main mechanism of healing here is regeneration. And at the end, there's a small scar formation and minimal contracture, if you can see. So here there's a narrow scar, and wound contracture is very slight. However, in healing by secondary intention, there's a gaping wound usually. So according to that, we need a larger granulation tissue that is highly vascular to accommodate this destruction. And it usually results in a large scar and contraction by myofibroblasts. You can see the wound contraction here is very high. So myofibroblasts are cells that have actin, so they're kind of like muscle cells, somewhat. So they act to pull your tissues together to help close the wound. So if we want to go over the slides, 1, primary intention, healing by primary intention, or first intention, they're the same. It's usually a clear surgical incision. There's no significant bacterial contamination because, as we'll discuss later, bacterial contamination or infection delays wound healing. There's minimal loss of tissue. There's clot or scab formation, so a very small scar. Healing by secondary intention, it occurs in large gaping wounds as well as those that are infected or that contain foreign materials. These are all factors that delay wound healing. Here there are more extensive loss of cells, so there might be infarction and necrosis, so death of the cells, which hinders their proliferation, even if they were capable of proliferation. So even if they were labile or stable cells, if there's infarction, they might not be able to proliferate. There might happen inflammatory ulceration or an abscess formation. The surface wound is large, and there's usually a tissue defect that must be filled. So there's extensive deposition of collagen, and there's a scar formation. Not metalloproteinases, myofibroblasts help in closing the wound because it was so gaping and so large. So they are very necessary here. They close the wound and cause contractures. So if we want to compare them, the basic process of healing is the same in all wounds. In contrast to healing by primary intention, wounds healing by secondary intention, 1, require more time because the wounds are larger, they might be infected. 2, they show more prominent inflammatory reaction, so there's granulation tissue formation, and there's granulation tissue formation. So prominent inflammatory reaction is necessary to eradicate any causative infection if present. And that's it. And there 3 could be a copious granulation tissue, which is necessary for vasculature and to recruit the necessary cells for the healing process. And 4, secondary intention healing displays wound contraction of 5 to 10%, which is caused by myofibroblasts. I hope the difference between the two is clear. Now we're going to go over factors related with delayed wound healing. So we just mentioned there's infection because it will prolong the inflammatory reaction because the body will need more time to eradicate a causative organism. 2, foreign bodies in the wound also delay wound healing because the body will need to eliminate this if it's not naturally eliminated. 3, mechanical factors. So sutures, for example, can help in wound healing. However, if you have a scar and the suture is closed, but if you move a lot, the suture can open, and this can delay the wound healing. So sutures can help, but for example, movement and disrupting the normal healing process, for example, will delay it. There are also nutritional deficiencies, so protein deficiencies with vitamin C deficiency inhibit collagen synthesis. Now, vitamin C is very necessary in forming collagen, so any defects in formation or in your nutrition can delay wound healing by delaying collagen synthesis. If there is poor perfusion due to either arteriosclerosis, because in arteriosclerosis your arteries are slightly plugged, or in diabetes, or in obstructive venous drainage. So all of these cases will hinder the recruitment of cells to the site of inflammation or injury, site of injury. 3 is excess corticosteroid use. Corticosteroids are anti-inflammatory drugs, so they inhibit inflammation, and if inflammation is not completed, the repair process won't be completed. It makes sense, I guess. So inflammatory effects glucocorticoids are sometimes desirable. Yes, this is also an exception. So they're sometimes necessary, for example, in corneal infections. Now, my understanding of this, and I'm not really sure about it, is that we wouldn't really want a scar to form in your eye, but I'm not really sure about that. So just know that this is an exception of of the use of anti-inflammatory drugs, which are corticosteroids. Now, if we want to go over the complications of wound healing, it can be either one of 3. There can either be a deficiency in the scar formation, or 2, excessive formation of the repair components and connective tissue, or 3, the formation of severe contractures. So if we want to go over them, we're going to go over them one by one. So deficiency in scar formation, there can either be wound dehiscence or wound ulceration. So wound dehiscence is for the wound to reopen after closure. For example, if you suture the wound and it opens again, so this is wound dehiscence. Ulceration is failure of the wound itself to close. 2 is excessive formation of the repair components. So there are keloids and hypertrophic scars, and we're going to go over them in the next slide in detail. 3, there's formation of contractures. Now, as I said, contractures are sometimes necessary if the wound is so gaping to bring the sides of the injury together and help in closing it. However, if they are in the palms, for example, and soles, they're very common in the palms and soles of feet. But if they're in your hand, for example, they can hinder your movement. And they're commonly seen after serious burns, if you've seen them before. So I don't know if this image is clear, but you can zoom in and look at how here and here the contractures are very visible. So again, they're common in the palms and the soles of feet, and in the anterior aspect of the thorax, so in your chest. They're commonly seen after burn injuries. They can compromise the movement of joints, as I said, depending on where they are. And 3, they are caused by myofibroblasts, which are cells that have actin and act slightly like muscle cells. So if we want to compare keloids and hypertrophic scars, these two are complications where there's excessive formation of repair products. So we're going to go over keloids. Now, keloids result of an overgrowth of dense fibrous tissue that usually develops after healing of a skin injury. They extend beyond the border of the injury. So, for example, the injury was a slight line like this. If this was the main injury, for example, A keloid would go over the boundaries like this, as you can see in the image. They do not usually regress spontaneously, and they happen after an excision. So they usually are very difficult to remove. So even if you excise them and try to remove them, they usually come back. So this is a very severe complication, I would consider. However, hypertrophic scars are characterized by erythematous, so red, pruritic, meaning itchy, raised fibrous lesion. They do not expand beyond the boundaries of the initial injury. As you can see, they're on the boundaries of the injury. They may undergo partial spontaneous resolution, unlike the keloids, which do not regress normally. They need to be excised surgically. These need to be excised surgically. These can go spontaneous resolution. And finally, hypertrophic scars are common after thermal injuries. If you have any burn scar, they usually end up looking like this. So both hypertrophic scars and contractures are common after burn injuries or thermal injuries. Now this is the end of the lecture. These are some messages to take home from this lecture. 1, there are various cell types, labile, stable, permanent cells, and each one of these affects the outcome of healing and determines which type of healing process will occur. There are 3 main phases of scar formation. 1, scar formation. 1, inflammation. 2, formation of a granulation tissue. And 3, remodeling. Now, for cutaneous wound healing, there is either healing by primary intention, which occurs in surgical, clean wounds, and healing by second intention, which occurs when excessive tissue damage is present. Now, there are several factors associated with delayed wound healings that we discussed, such as infections, mechanical factors, for example. And finally, we discussed the complications of wound healing, such as contractures and excessive scar formation. The resources used for both of these lectures were the Robbins Basic Pathology by Kumar, the 9th and 10th editions. I think the one used by the university at this point is the 10th edition, but I refer to this as well. And the 2020 KSU lecture slides. Now again, I did find these slides slightly confusing, so I did change them up a bit. I went back to the Robbins textbook, so if you want to depend on my slides, feel free to do that, but please compare them with your batch's slides when they come out. Now for any additional resources, I highly recommend Ninja Nerd for anything, really, but specifically for inflammation. There is a 5-video series. They might be long, but you can look at the first one. It covers both elements of immunology and pathology related in relation to inflammation. It's very amazing. I really highly recommend it. And there's osmosis. It covers also some topics slightly, so you can check it out as well. Now, thank you for listening. This is my contact if you have any question. I really do hope that these 2 lectures are clear and that I helped even slightly in simplifying them. So please contact me if you have any questions, if you have any feedback. Thank you for listening. I really appreciate it. Good luck and goodbye.